Well, as anyone who has a chronic disease can tell you, one of the most common questions you're going to be asked is, how are you feeling? And the most likely answer that you're going to give is to say fatigued. And that's not really a coincidence. Profound and debilitating fatigue is the single most common complaint that is reported by people with chronic inflammatory and autoimmune disease. And it's reported by about 90% of people at one point or another. The thing is, it's pretty difficult to define it. It's a little bit like the old joke about the Supreme Court's definition of profanity, is that you know it when you see it. You certainly know fatigue when you feel it, and it has a significant impact on quality of life and on the overall sense of well-being that a person has. Now, the usual definition is that it is a general lack of energy that prevents you from engaging in normal daily activities, often with a lack of desire and motivation. It can end up interfering with mood, with social activity, or limit physical activity and your work. And it clearly has an impact on overall quality of life. Now, to be sure, fatigue is not the same as sleepiness. And that's why I have this slide here, even though the two things are clearly interrelated. Now, sleep deprivation can result in fatigue, and diseases that cause fatigue are associated with higher rates of sleep disorders. Now, with regard to people with chronic liver disease, sleep disorders have a high prevalence, higher than in the general population. And there is a growing body of information and of evidence about the role of inflammation in triggering fatigue. And we'll discuss its connection with sleep in a few minutes. Neurologic inflammation is a primary factor that contributes to fatigue. Inflammation is altered by a lot of the factors that themselves modulate fatigue, and vice versa. Chemicals that are used by the immune system that coordinate their activity are called cytokines, and some of the pro-inflammatory cytokines have been shown to induce fatigue and what you might call sickness behavior in animal models. And while you might wonder how you could measure fatigue in a lab rat, it's actually done by giving the animal a choice between things like low effort, low reward behavior and higher effort, higher reward behavior. So for example, if a rat has to just push a small curtain to get to one piece of rat chow, that might be low effort, low reward. But if it has to navigate a maze or climb up some steps to get an unlimited amount of rat chow, that would be a high effort behavior. And when you apply some of these inflammatory chemicals to their brains, the rats will consistently choose lower effort behavior. So they're behaving like people who are fatigued and suffer from a lack of motivation and desire to engage in the world. There are similar studies that actually show that these rats are less likely to socialize, they won't investigate a new environment, and overall, that the expenditure of effort is connected with the inflammatory chemicals that are being applied to their brains. Now, as it connects with humans and with inflammatory diseases in humans, there is a fair amount of evidence that the vagus nerve, which carries input back to the brain and vice versa from the abdominal viscera, can trigger these very same neurochemical events in the brain and potentially induce fatigue. So people with things like inflammatory bowel disease, autoimmune hepatitis, lupus with abdominal visceral involvement will experience fatigue, not only with the actual symptoms that they're experiencing from their disease, but also on a neurologic basis. Now, although sleep and fatigue are not the same thing, they clearly are interrelated. Many individuals with autoimmune diseases will report disturbed sleep, and conversely, chronic insomnia seems to be associated with an increase in the risk of developing autoimmune disease. So, for example, an increased risk of restless leg syndrome is associated with autoimmune diseases like multiple sclerosis and rheumatoid arthritis. Conversely, a lot of people with autoimmune diseases have chronic pain, and more than 3/4 of people with chronic pain will report disturbed sleep. So the relationship really does seem bidirectional, and in fact, people with insomnia will also indicate that they feel enhanced pain. Lastly, sleep disturbances will enhance the expression of these inflammatory cytokine chemicals. And so that can both aggravate the sleep disturbance and enhance fatigue. Now, as I segue over into discussing actual sleep, it's important to make sure that I don't say something that's both true and misleading. Sleep disorders are extremely common in the general population, and certainly with regard to sleep apnea and the rising incidence of obesity in this country, it is becoming even more common than it had been. Nevertheless, these disorders do seem to be more common in people with autoimmune disease, and in particular, people with chronic liver disease. Traditionally, disordered sleep had been attributed to the presence of neurologic and cognitive issues, such as are seen in hepatic encephalopathy, but they really can be present even in the absence of HE. Like fatigue, sleep disorders are associated with psychological problems like anxiety and depression, as well as just difficulty in maintaining normal activities of daily living. So they can have a significant impact on how a person is able to function and cope during the presence of a chronic disease. Now, one thing that I do want to emphasize is that most of the literature that discusses sleep disorders and chronic liver disease does not distinguish among the different causes of chronic liver disease. So that although there's some limited information about different disease groups, for example, alcoholism versus non-alcoholic fatty liver disease, or some of the different forms of chronic viral hepatitis, there's really limited information in terms of subdividing it and characterizing sleep disorders as they relate to individual categories of liver disease. So most of the epidemiologic studies really talk about sleep disorders in people with frank cirrhosis, and even not necessarily with milder stages of liver disease. Now, when someone is describing sleepiness, it can happen either from sleep deprivation or from sleep fragmentation, and it can vary over the time of day, no matter what has happened over the course of the night. In other words, being sleepy does not necessarily mean that the ability to take a nap, for example, or that the effectiveness of a nap is going to be the same over the course of the day. Now, in general, when we are talking about sleep disorders and chronic liver disease, we mainly are focusing on the four that are on this slide. The most common ones are insomnia, excessive daytime sleepiness and sleep apnea, and restless leg syndrome. Now, again, we often consider insomnia in two ways. There's sleep onset, in which you have trouble falling asleep, and sleep maintenance insomnia, in which you have trouble remaining asleep. Sleep maintenance insomnia can often tie in with other diseases. So a person who has a movement disorder, such as restless leg syndrome, may fall asleep, but many restless leg patients often have periodic limb movements during sleep, which can cause fragmentation of their sleep and cause awakenings. Similarly, people who have sleep apnea will have frequent arousals during their episodes of apnea, but sometimes those arousals will lead to actual awakenings, and they may then have difficulty falling back to sleep in the middle of the night. So overall, insomnia is present in about half of patients with cirrhosis, even when that cirrhosis seems well compensated, and there does not seem to be an association between insomnia and HE or neuropsychiatric impairment. One of the earliest descriptions, and we've known about sleep disorders and liver disease for decades now, one of the earliest descriptions of it had to do with delayed sleep onset, in which the patients were simply shifting their sleep phase and falling asleep later in the night, and similarly sleeping later in the day, and also having daytime sleepiness. And I'm going to touch on this a little bit later when I talk about melatonin. Now, excessive daytime sleepiness, or EDS, is one of the main complaints in people with cirrhosis, and for that, there does seem to be a connection with hepatic encephalopathy. Obstructive sleep apnea, or OSA, has a two-way relationship with fatty liver disease, for example, because about 30 to 40% of people with obesity and fatty liver disease have sleep apnea, but conversely, people with sleep apnea are anywhere between 3 and 5 times more likely to actually have fatty liver disease. And there also seems to be a relationship between sleep apnea and the progression of fatty liver disease to cirrhosis. It's thought that the episodes of low oxygen level and then rebounding oxygen levels contribute to what's called oxidative stress and to the development of cirrhosis instead of having stable fatty liver. Restless leg syndrome, or RLS, also seems to have a higher frequency of occurrence in chronic liver disease. And the percentages in this slide seem so wide is probably because reporting is affected based on the racial and ethnic groups that are being described. It seems to be a little bit more common in white Europeans than it is in Asians, for example. So the numbers can vary more widely depending on who's being studied, but it certainly is more common in chronic liver disease patients than it is in the general population. Now, among the different mechanisms that have been proposed for these abnormalities of sleep are things like changes in melatonin metabolism, changes in thermal or temperature regulation, and increases in the level of ammonia across the blood-brain barrier. And all of these things are still being investigated. None of them are definitive, but they all have some very interesting concepts behind them. So for example, the circadian rhythm for sleep is affected by light use. And among other things, melatonin is the messenger for that. So exposure to light affects the release of melatonin, which in turn affects the onset and maintenance of sleep. So melatonin levels are higher during sleep and they're suppressed by the presence of light. But in patients with cirrhosis, melatonin patterns change. Levels are higher in the daytime than they are in patients with normal liver function. The rise that's associated with sleep onset in the evening tends to be delayed, which may account for the delay in sleep onset in people with chronic liver disease. And overall, the pattern shows that type of phase shift. What's more, even though the findings are interesting, the link is not quite so solid because there's no clear connection between liver function chemistries or ammonia levels and melatonin levels. So on a practical basis, it's not something that is easy to track or even predict in the average patient on a day-to-day basis. So the ability to make conclusions that might have an impact on everyday patient care is still a little bit problematic. Ammonia levels and some other neurotoxins that are encountered in hepatic encephalopathy can change neurologic and neurochemical transmitters in the brain, and some of them do have effects on melatonin, on the circadian sleep cycle. They will have an impact on the electroencephalogram with subsequent noticing unrestful sleep or even excessive daytime sleepiness. The interesting thing about hepatic encephalopathy, however, is that even though it may be related to EDS, it's not clearly associated with nighttime sleep disturbances. So people with hepatic encephalopathy may report daytime sleepiness, but not necessarily have a disorder of sleep itself. And I had mentioned also about thermal or temperature regulation. One of the interesting things that happens to your body at night is that your core temperature tends to fall as you shunt blood away from your abdomen and out to your extremities. And the gradient between your core and your extremities can be used as a predictor of the onset of sleep. In people with cirrhosis or with portal hypertension, there is an increase in circulation at the core, and the patients are unable to lose that heat, and that also seems to correlate with a longer sleep latency. Now, assessment of a sleep disorder is both, I'm sorry, I think I'm missing some slides, so I may have to come back later. Assessment for sleep disorders is both subjective and objective, and I would simply point out that the most common tools that are used will evaluate several things. One is just a general sense of sleepiness, and for that we use something called the Epworth Sleepiness Score, which involves about 8 questions asking people about their likelihood of falling asleep under different circumstances. And we'll ask them to grade it on a scale of 0 to 3, where 0 is no, it would never happen, I would never fall asleep. 3 is, oh yeah, that's me. And 1 and 2 are somewhere in between. And the higher the score is, the more sleepy it indicates the person feels. Then there's something called the Pittsburgh Sleep Quality Index, which doesn't so much measure sleepiness as it does the general perception by the individual about whether they felt that they had a good quality sleep. And it's a questionnaire that is not typically used in the office setting. It tends to be more of a research tool simply because it's several pages long. It's a bit more cumbersome, but it can be used when you're studying interventions in helping your patients sleep better. And then there's something called the Stop Bang questionnaire, which many physicians are using. The Stop Bang questionnaire is an attempt to help predict the likelihood of sleep apnea by looking at things like neck size, the presence of hypertension, the presence of obesity, and several different parameters that are easy to record and often can be recorded even by someone other than the patient. Now, in terms of actually testing sleep, the gold standard for sleep apnea and for things like periodic limb movement disorder is to actually have people come into the sleep laboratory for what's called polysomnography. It involves having electrodes on all their limbs, on their scalp, to record the different sleep stages, as well as recorders of their respiratory status and oxygen levels. You can do home testing, which doesn't measure the electroencephalogram pattern and doesn't always measure motor activity, but does measure pulse rate, oxygen level, and breathing pattern. Restless leg syndrome is often a clinical diagnosis, although its partner, periodic limb movement disorder, really would need a full in-laboratory polysomnogram to diagnose. And then there are some of the diagnoses that are simply made clinically, such as insomnia, whether it's sleep onset or sleep maintenance, and restless leg syndrome itself, which is based in large part on the patient's description of their diagnosis. Now, in terms of treatment, first and foremost, I would throw out there the recognition and treatment of hepatic encephalopathy, even if it is at a milder stage. Now, there are studies that have shown that treatment of hepatic encephalopathy with lactulose, and to a lesser extent, there's data on rifaximin as well, showing that not only is the encephalopathy improved, but also that sleep quality is improved as well. So the benefits do seem to be fairly consistent with that. Then there's the use of melatonin, and melatonin has not been specifically evaluated in chronic liver disease, but because it has been shown to play a significant role in a lot of primary sleep disorders by improving sleep latency and sleep quality, and because it really has no known adverse effects, it's often recommended because it just seems to be a reasonable option for treatment. Believe it or not, zolpidem or Ambien has been tried even in patients with chronic liver disease to some beneficial effect. I personally have never used it because I tend to avoid anything really that has consistent sedative hypnotic effects. CPAP therapy obviously is beneficial, but only in people with clear-cut obstructive sleep apnea. And the management of sleep apnea in chronic liver disease really is no different than it would be in any other patient with that condition. Atarax, which is the brand name for hydroxyzine, has also had some short-term studies done that show benefit with improved sleep efficiency and subjective sleep quality. I honestly don't know if that's just because the patients had improvement in pruritus and itching, or if it's because of the mild sedative effects that many antihistamines have, but it has been studied and specifically studied in chronic liver disease. Modafinil is a drug that we often use in people with narcolepsy, as well as in patients who have excessive somnolence despite treatment of their sleep apnea. And it also has some limited data to show benefit in managing excessive daytime sleepiness. Light therapy, surprisingly, has not been shown to be a benefit, and it's been a bit of a disappointment because one would have thought that you could use it to help reset the normal circadian rhythm. And non-pharmacologic therapies, things like lavender oil and stress management and meditation have been shown to be beneficial both in general populations with sleep disorders as well as in people with chronic liver disease. So to sum it up, the disorders themselves are more common in people with chronic liver disease. We don't have a lot of data on the different subdivisions and different subtypes of chronic liver disease. The management is largely the same, with the exception of some of the pharmacology. Obviously, people with limb movement disorders have to pay attention to whether the drugs they're using are metabolized by the liver, but none of the drugs that are used, things like ropinirole, for example, none of them are specifically contraindicated in liver disease, although some of them do have to be dosed differently or used with a bit more caution. So I think that's a brief intro to sleep disorders in liver patients, and I'm open to questions if anyone has them.